Good evening. My name is Bill Henrich, and I am the president of the University of Texas Health Science Center. I'm a member of this club with my beautiful wife, Mary. Mary, wait for him. We are here from time to time, but haven't had the chance to meet many of the members who are here tonight, but I want to thank all of you for coming. Thanks for being here, and I know this series has been popular, and I hope tonight is no exception. My job is to introduce our guest, Dr. Sudha Seshadri, and I'll do so by saying that this creation of a neurodegenerative center in San Antonio was the result of a meeting I had with a person many in the room know, a man named Glenn Biggs. Yes. Glenn Biggs and Ann Biggs were popular members of our city. Glenn was a very well-respected banker here in town. And now it's been about 5 years ago that he came to see me one afternoon in my office and told me that he was in the early to moderate stages of having Alzheimer's disease. And he asked me where he could go and what therapy he could receive to help him. So I did some research, and I found that there are really no truly comprehensive Alzheimer's disease centers in Texas. There are Alzheimer's research centers in Texas, but there really are no Alzheimer's comprehensive centers. And by that I mean where there's care and accurate diagnosis for patients and staging of them at the early stages of their disease, care for the caregivers, which is, as many in the room know, a massive problem in this disorder. And then the availability of putting people on clinical trials, because the way these diseases that are so vexing are ultimately defeated is through the conduct of biomedical research. It's the answer to all of these very difficult, complex questions. And that wasn't available in San Antonio. And when you think about the fact that we are an aging demographic here, the number one risk factor for getting Alzheimer's disease is your age. And then the second thing is that it's more common in Hispanics, 30% more common in Hispanics. You can see that we are in the epicenter of the tsunami of Alzheimer's coming down the pike. So I felt it was important for us to establish an Alzheimer's center. I went out and began to test the waters for whether there was an appetite for establishing such a center, because I knew we couldn't recruit somebody as luminous as Dr. Seshadri unless we had the endowments already here, unless we already had the cost of the operation of the Alzheimer's Center already here. I'm pleased to say that this effort was supported in a robust way. And in a little over 2.5 years, we've raised over $40 million for the center. How about that? That's not bad for San Antonio. So what happened then is I went out and began to scour the country for the best person in the country to lead the Alzheimer's Center, the Glenn Biggs Alzheimer's Center. And I'm pleased to say that she is in the room tonight. Her name is Sudha Seshadri. She formerly was a professor of neurology at Boston University School of Medicine. She's one of the more decorated thought leaders in Alzheimer's disease in the world. I'll tell you one story and then I'll stop. One story is that to get one NIH grant, a grant from the National Institutes of Health, is a daunting task. If 100 of them are sent in today, the success rate will be about 7 in 100. In other words, 93 in 100 don't get funded. So to have one NIH grant is a milestone. I don't know how to even convey what it means to a person who's trying to get these grants. Sudha has 9 NIH grants. So you can see from that, she is a world leader in all aspects of this disease. So she's hit the ground running. She's been here since December 1st, and in that period of time, that short period of time, has recruited a number of people to San Antonio. Scientists, pathologists, PhD scientists, clinical trialists. Carol White is in the second row. Raise your hand. Carol White is the head of the Caring for the Caregivers program. That's her. She's Dr. Carol White is a nurse who is a world expert on caring for the caregiver, and she is partnered with Sudha in this efforts. So as you can tell, I'm incredibly proud of Dr. Seshadri. I'm incredibly proud of Carol. I'm incredibly proud of the Glenn Biggs Center, and I hope this presentation and the questions are informative. Please welcome Sudha Seshadri. There you go.
Thank you. Thank you so much. So I know this is supposed to be a fireside chat, so I apologize for slides. I'm going to run through them fairly quickly so we have a little more time for questions. So I thought I'd touch upon, the title was Preventive Cognitive Decline in Dementia. So often there's a question, how do we know? Is this just normal cognitive decline of aging, or is this actually dementia? And so I thought I'd start there. Another question I'm often asked is, what's dementia? Does this person have dementia or Alzheimer's? So I thought I'd touch upon how we, from a scientific point of view, look at the two and their interaction. And then the all-important question, how can we keep from getting this horrible disease? And finally, if somebody does have dementia, what might be the best thing we can do for them today? So I want to begin by saying that what happens to us when we age is really a function of our whole life. So it depends on our early life, how much risk or reserve starting in utero, and then as one gets older, some stages preceding dementia have been defined. There's something called subjective cognitive decline, which doesn't always precede dementia, but sometimes does. And that's when the patient feels that something might not be okay. But when you test, everything seems okay. We don't quite know the significance of this. Many people with subjective cognitive decline are actually okay. They're just worried and well. But a proportion of them go on to the next stage of what we call mild cognitive impairment. That means the person feels something is not quite right, or a loved one feels something is not quite right. When you test, they've either gone down from where they were, or they test in the bottom 10 or 12% for people of their age and education and sex. So you think something is not okay, but they are doing everything they want to do. So they're performing fine by just compensating for it in different ways. And we call that mild cognitive impairment or minor neurocognitive disorder. About 15% of people with MCI go on each year to develop dementia, which means 85% don't. So it's very important to actually pick up in this early stage of mild cognitive impairment, because that gives you the best shot at preventing further progression. An important thing to remember is that the further on one is picking up something, the less the chances that anything we do is going to be effective in keeping the person from developing dementia. So there are a number of, the most important thing about dementia, the way we define it, is that there is a cognitive and behavioral change compared to what this person was able to do earlier. And it's bad enough that it keeps them from doing something, from living their life the way they want to. Okay? So there's a cognitive or behavioral change, and at that stage it's often either persistent or even progressive. Our hope is to have treatments that we can reverse, but we are not there yet. So often the best thing to do when you think there may be something is talk to your primary care doctor. There are small batteries like what I've shown here. That's just 8 questions. It's called the AD8, and these sorts of things can help screen. Different doctors use different things, but it's always a good idea to talk. And these are some of the symptoms which I'm sure, unfortunately, most of you are probably familiar with. The important thing I wanted to point out is it's really a continuum. So we all have, we all have we may begin with, occasionally anybody can misplace their keys. So that doesn't mean you get alarmed. It's when there's a consistent pattern with these symptoms of forgetting, of not remembering things even when you're given clues, of not knowing where you are or who is the person in front of you. And an important thing to remember is that the disease kind of goes backwards. So the first things you forget are something that happened a month ago, and something that happened 30 years ago you may remember in vivid detail because that memory is really embedded. And this can be very frustrating for a caregiver who says, how can you remember that and not remember this? There can be trouble with knowing what things are, knowing which car in the parking lot is yours, or how to get around a place. There can be some types of dementia can begin with difficulties with speaking, so we call that, and communicating, we call that aphasia. The person may just speak less and less, or have trouble finding the right words, or trouble with names, or they may bring in strange words that are not in the dictionary, or those are called neologisms and paraphasias. And again, some people who are bilingual may remember their childhood language and forget a more recent language. The biggest thing, though, is that they often lose that initiative or the ability to inhibit themselves as appropriate and to organize and multitask and figure out how to do things. And they may be fine in normal situations, but if there's a stress, it's Thanksgiving dinner, it's the alarm goes off, fire alarm goes off, those may be the situations where suddenly this comes. So often holidays are a time the disease comes to light because the situation is stressful, there are new things and the person can't cope. However, some people don't begin with memory or thinking problems at all. They may begin with changes in appetite or weight loss. They may begin with changes in sleep or depression or anxiety. And again, this is important to consult with your doctor. Sometimes there can be hallucinations where you're seeing people who aren't there, or strange things like cats, or believing things that aren't real, or being paranoid or agitated, or having trouble doing things like you have a new remote and you don't know how to use it. And those things are called apraxia. We all do that in the beginning. The point is, fair enough. Fair enough. Anyone who is over the age of 15 has had that problem. But if it is sort of a consistent pattern of challenge whenever something changes. So what I want to point out is that we all begin with cognitive reserve. For the first 20 or 30 years, things keep getting better. And then we do find that certain abilities go down, like the speed of the response or the density of the memory. However, other things compensate. You're often able to make richer connections, for instance. But in many people, at a certain age, what happens is that one starts to go down. And that's sometimes been called aging-related cognitive decline. There may be some pathology here as well. But then there are a number of known pathologies that can make this happen faster. And once a person reaches a stage where it's affecting their function, we call it clinical dementia. It's important to remember that some people who reach here can actually get back better because the reason they got here is because they were taking a medication, medications for glaucoma, for urinary problems. These can all cause worsening of memory. They may be having depression. Although depression can be the first symptom of Alzheimer's as well, so it can be hard to tell. There are a few rare deficiencies like B12 or thyroid that can present as dementia, but by and large, vitamins don't help. And they can be diseases in the brain or body. There may be a tumor or disease of the liver or kidney or cancer, which is another reason to go and talk to the doctor, because anything can present if it is impacting the function of the brain, even if it's not primarily dementia. Again, for people who might want to get a perspective from the patient or the caregiver, these are some resources. Dr. Winokur is in San Antonio itself, and I loved his book. There is the virtual dementia tour that Dr. Carol White and the Alzheimer Association organize, if you're interested. This is a book written by a patient, Gerda Saunders, that I again found very beautiful. So, leaving it there, let's explore for a minute what is behind the disease, what is the biology. An interesting fact is that there's a study called the Nun study. We now call it the religious order study. You may have heard of that. So about 700 nuns decided to be tested every year and then donate their brain when they died. So you know exactly what their memory and thinking was the year before they died, and then you can relate that with their brain. And what was seen was that people without dementia as well as people with dementia both had Alzheimer type pathology in the brain. But people with dementia typically did not have normal brains, they had many other things wrong as well. Whereas people who seemed to have good memory when they died, even though some of them had Alzheimer's, some of them seemed okay. So it's complex. It's not just a simple what's in your brain, it's what's in your brain, where did you begin, how many things are wrong with your brain. And that's why you need to work with the neurologist to understand that. So dementia is a syndrome. Like I told you, that is you're forgetting things and you can't do the things you want to do. Or you're behaving in different ways and that's keeping you from doing the things you want to do. But there could be many things wrong in your brain when you have dementia. The commonest thing is Alzheimer's. We believe Ronald Reagan had that. The next commonest thing is vascular brain injury. Ariel Sharon had multiple strokes. Another common cause is Parkinson's related, or what's called dementia with Lewy bodies. This often has bad mood disturbances, hallucinations. We think Robin Williams had this. And frontotemporal dementia is another type of dementia that often begins actually younger, when people are in their 50s or early 60s, and sometimes it can bring out things that they did not have before. It's thought that Maurice Ravel had frontotemporal dementia when he wrote Bolero, and that explains the kind of very repetitive pattern in the music. What is Alzheimer's? There are two. It was the disease described by Alois Alzheimer in a 51-year-old lady, and it was only about 70 years later that people realized that most dementia in older people was because of Alzheimer's. The two big hallmarks are what are called tangles, and this is from Alzheimer's description, which is still good today. Within the neurons, these are neurons, you get these tangles, and these are made of a protein called tau. And outside the neurons, you get these, they are called plaques because they look like plaques, and they are made of a protein called beta amyloid, which is really not soluble. So what happens is that there is a protein in our membrane that we all need, but in Alzheimer's, it gets broken up in an abnormal way, and then it forms these clumps which then kill off the neurons. And this amyloid can be seen today during life with a PET scan. This is an Alzheimer brain, you see it lighting up, and this is a normal brain without the amyloid. It can also now be detected in the spinal fluid, or more recently even in the blood. And there are now tests that look at tau as well as how much your glucose your brain is taking. We have the capacity to do all these tests in the Health Sciences Center. I just wanted to point for a minute. I told you that frontotemporal dementia can take away your speech and behavior, but it might, in some people, give a gift of greater visual creativity. And so these are scientific papers by Bruce Miller, whose mother was artist. And this is one of his patients who was a weekend artist. And then in the early stage of frontotemporal dementia, you can see how she can't speak but can express her emotions in her art. So dementia is a journey. Too many of us will have to take. But let's look for the gifts. Let's look for the blessings along the way. I hope we can stop it, but in the meantime, let's keep a positive attitude. So, how can we prevent dementia? Every 65 seconds, somebody is diagnosed with dementia. That's about 6 million people living with the disease today. And 1 in 3 of us, if we don't do anything about it, is going to die with the disease. It's the only one of the top 10 causes of dementia that's going up rather than down. And causes of death, sorry. And for every 1 person affected with dementia, there are 3 care partners whose lives are also turned upside down. Many of these care partners are quite young, under the age of 35. It costs the country nearly 300 billion each year, and by 2050, all these numbers will be tripled. It costs an individual family often a third to almost all of their lifetime savings, just providing care for the person. So, Texas will be particularly hard hit. It already has the 3rd largest number of people with the disease, is 2nd in death due to Alzheimer's disease. And part of this is because, as Dr. Henrich explained, Hispanics have a higher risk. However, and Hispanics the numbers will increase 6 times versus 3 times in everybody else by 2050. However, they are less well studied. They are harder to reach, harder to enroll in clinical trials. Instead of the expected 20%, only about 1% of people in clinical trials are Hispanic. And there's a higher care burden because there's this very strong sense of family obligation, so everybody gets pulled into care. But I believe in the next 10 years, we are in the place in terms of the political will as well as the technical capabilities to make Alzheimer's manageable in 10 years, where about a third of people it will be preventable, in a third we'll be able to arrest it, and in a third we'll be able to slow progression after diagnosis and reverse some symptoms. How? I do think that prevention is the key. So let me just touch upon some things about prevention. A lot of the research I'm going to show you is based on my work with the Framingham Heart Study. It began in 1948. This is a first generation participant, 2/3 of everybody living in the town then. In 1971, children of the original cohort were enrolled, and in 2002, grandchildren. At the 50th anniversary, this is now the 70th year, the people of Framingham put up these plaques, proudly stating the town that changed America's heart. San Antonio has a long tradition of discoveries, path-breaking in breast cancer, in stroke, in aging, and I'm hoping we can call ourselves a city that really contributed to ending Alzheimer's. Let's take it as a challenge. So one of the things that Framingham showed was that over the last 30 years, actually, although the total number of people with dementia has not decreased, and given person's risk of dementia has gone down, the age at which they get it has increased by about 5 years. So we said, that's interesting, that's hopeful. Let's see what we are doing right. We don't know if this is true in Hispanics and Native Americans because the Framingham population in 1948 was all European. And part of it is we are doing better at controlling blood pressure, stroke, preventing or treating atrial fibrillation. We are not really preventing it. But that's just a small part of the explanation. So we looked at a lot of other factors. Some of it is early education and nutrition. That determines the cognitive reserve I told you about. Some of it could be things like better control of infections with vaccination, less pollution. But these are some of the changeable, modifiable lifestyle factors that I'd like to just touch upon, and then I'll be happy to answer questions. An article in The Lancet pointed out that in early life, education might be the number one thing. In midlife, control of blood pressure, treating any hearing loss, this was relatively new, and controlling high weight, these might be beneficial. And in late life, not smoking, treating blood pressure, and staying cognitively and socially engaged seem to be the big things. So this is some data from Framingham, and I have an important message here. What we saw was that people who didn't move at all, who were in the bottom 20% of physical activity, had a higher risk. But everybody else was okay. And it was what you did in midlife that mattered as well. And the reason I'm bringing this up is that any steps at all is better than none. If you find people who don't meet the American Heart Association guidelines of exercising for half an hour 5 times a week, don't worry. I mean, it's better if you can manage that, but even if you can't, for every being in a little more steps per day, the brain size was better preserved. So the most important thing is to begin some kind of physical activity. With diets, there is the Mediterranean diet with fruits, vegetables, the MIND diet, which is also lower salt, a little wine in moderation, fish. Some people find the ketogenic diet helpful. What everything has in common is that carbs and sugars are probably not good for you. One of my colleagues, Matthew Passe, he was here in January and he gave a public talk, some of you attended, showed that if you have sodas, there's about twice the risk of developing dementia. And even if you don't develop dementia, having more sugar-sweetened drinks meant that your memory performance was worse. This is more than 2 drinks a day, this is no drinks a day. So that's something we can cut out. There's a protein called brain-derived neurotrophic factor. If you have more of that, there's a lower risk of dementia. And what Joel Salinas, he has given a TED talk, for those of you interested, noted was that if you have more emotional support in your life, there's 30% higher BDNF level and 30% lower risk over 10 years of developing dementia. So he's been funded now to do a study of social networks and how that might be beneficial for preventing dementia. Then there is sleep. Some years ago it was shown that when you're in deep sleep, you find that the amyloid protein in the brain that I told you about gets cleared, whereas when you're awake, it doesn't get cleared through some pathways along the vessels. So getting enough sleep seems important. But a lot of sleep, sleeping more than 10 hours a day, seem to be associated with a higher risk. We don't think it's causing it, we think it's just an early marker. Having more dream sleep seems to prevent or protect from dementia. So that's a good sign as well. So there's a big grant that we're going to be doing, leading out of here, looking at sleep in multiple cohorts. There are now trials. The study that's, there's a center now in Dallas and we hope to bring it here soon. It's called a pointer study where you have exercise, diet, cognition all together being offered as an intervention. There are prevention trials based on whether or not you have amyloid in your brain and whether or not you have a gene called E4 in the brain. So to sum up, what are some big ideas in Alzheimer prevention? There's about a 20-year period when we could pick up that you're at risk based on different things, and that's the time to enroll in trials. Having a heart-healthy lifestyle seems to help. For every 1 point on the AHA Simple 7, there was about 3 years younger brain that you had. And it's never too early to start. In fact, somebody who's 40 and has diabetes, the effect on the brain is like somebody 20 years older. Whereas if you're 65 and have diabetes, it's like somebody 6 years older. So midlife is a good time to start preventing dementia. And blood pressure control, exercise, and staying cognitively engaged seem to be the big things. So how can we help people who already have the disease? At the bigs, we recognize that this is really a group, a team effort. So we are building a team of people. We hope to provide advice for those who are worried, diagnosis for those who might have disease, as well as continued care as the disease progresses. Working with Carol White through the Caring for the Caregiver program, and we are beginning clinical trials. One of the early ones that we've already started enrolling for is a nicotine patch, because this seems to increase the chemical called acetylcholine that is helpful for memory without the toxic effects of smoking. So big ideas to stop or slow the disease. We have today just two groups of drugs that we use to palliate the memory symptoms. And then there are other medications for behavior and other things. The last approved drug was approved 15 years ago. And one of the reasons many trials have failed is because we are treating everybody with Alzheimer's like they have one disease, whereas we believe there are many ways in which you end up having dementia and Alzheimer's. And so understanding this difference and tailoring trials and treatment for each person is going to be the way forward. For instance, if you have people with these mixed biology and you treat them with something, you may have some people who respond, some people who don't respond. So overall, you can't make the difference. But if we could put people in the right groups and treat them with the right medicines, these may be medicines that are already there for something else and we just repurpose it, or they could be new drugs based on new biology. We are more likely to get answers. And this is a grant that's to look at biomarkers to try and put people in these different groups. So through genetic studies, we have realized that there are more than 30 genes that seem to have a role in Alzheimer's, and they point to many different biology pathways, and each of these is a potential drug target. It also seems that drugs that increase lifespan may be preventing Alzheimer's as well. So a drug called rapamycin that's been developed at the bar shop, now we are looking at it, we are applying to do clinical trials for Alzheimer's with that. But this has to be a partnership with all of you. How can people help? Sharing your story, sharing some details of your lifestyle, your medical records, your response. If you enroll in a clinical trial, you can give us permission to look at that data, to look at your response even outside the clinical trial. You can give us permission to keep your blood if we draw it for some testing for additional research. And this can be shared worldwide in a de-identified way. So precision medicine really needs having all of this, and it means we need people volunteering to be participants in such trials. Clearly, there can be ethical and legal concerns. And again, here we need the partnership of people in this room with the diversity of experience who can advise us in an ongoing fashion about the research we are doing and concerns that might be raised and how best to mitigate them. For instance, using these genetics and biomarkers, an individual could be helped because we could better predict risk. This is a colleague of mine, Sven. This is a project we were part of where it showed that beyond the gene ApoE, based on all those 30 genes, for somebody at 75, even if they had ApoE, they may have almost no risk, or they may have quite a high risk of over 40% over 10 years. You could then enroll in the right trials. You could find colleagues, not colleagues, people with the same disease in different parts of the world. There was a gene called TREM2 that was found in Iceland and Turkey, but the gene is relevant for people all over the world. And you may have safer prescribing. For instance, the drug we give everybody is something that increases the levels of a chemical called acetylcholine. But if you already have resistance to this drug, then giving it is not helpful, and that can be checked based on your genetics. We also certainly need to partner in understanding what's the most effective way to provide care. And finally, I'd like to thank the growing team, which includes people like Dr. Parker, who some of you may have met, and Dr. Sullivan, who's our neuropsychologist. So I'll stop there, and I'd be happy to take questions. Thank you all so much. Yes.
Are there particular foods that are especially good for the brain, number one? Are there particular, well, I would say things like Benadryl or antihistamines or aspirin or whatever that are detrimental to the brain? And as far as the lifestyle, exercising, things though like bridge or something like that that stimulates the mind, or continuing education or whatever. If you could just address that for me, please.
Thank you. Those are very important questions. With regard to the diet, there is observational data. That is, we find that people who have a diet that has more fish or that has more vegetables, fruits, the Mediterranean diet, or the diet that is more natural foods and less processed foods, seem to be at a lower risk of developing dementia. We are conducting double-blind clinical, not double-blind, but trials where some people are asked to change their diet and others are not. That's the best way of telling whether it actually prevents, and those are ongoing. With regard to exercise, as I mentioned, and as well as other things you brought up, staying engaged in ways that are pleasurable to you seems to be a big factor. One of our studies that I didn't show showed that if you have high stress, high cortisol, that seems to increase your risk of dementia. So anything that lowers cortisol, increases BDNF, increases oxytocin, these things seem to be good. So bridge is excellent. One of our Framingham participants was 105 playing bridge and driving down from New Hampshire. So I think those are, yeah, that's great. Generally speaking, you know, people often volunteer in an area they used to work in, and that's often very helpful. What's less helpful is, you know, sort of paying for a computer game. That's not the kind of rich, multidimensional experience that seems to be most valuable. Yes. Okay.
Just one more part of that. I've tried to get off of sugar, and so then I tried Equal, and then my friend said no, try Sweet and Low, and then my friend said all these different things. And it sounds to me like all of it is bad for you, right?
Unfortunately, yes. I think iced tea unsweetened.
To tag on to her question, because you brought it up, what is it about a soda that may accelerate dementia or Alzheimer's? Where did the test go that said something bad about a soda?
So it's probably the sugar content or the artificial sweetener content. It seems like the chemicals in almost all the artificial sweeteners that we have tested to date have effects on the brain which actually increases appetite and does other things. So artificial sweeteners, though they don't give you the calories, do have other bad effects. So it's most likely the carbon dioxide in the soda, the bubbles are bad for the bone, but we don't have any evidence that they are bad for the brain, so it's probably the sugar.
We've heard the expression chemo brain. I wonder if you can discuss the effects of standard chemo therapies for cancer patients as to their effects on the brain.
So chemotherapy, obviously, you're using very powerful drugs to kill the tumor, and that does have some effect on different parts of the brain, some drugs more than others. This is something that's being studied. There are also trials, including at the Health Sciences Center, to see if there are specific drugs that might be beneficial in that setting. One of them is for prostate cancer in that setting, whether a particular drug might be helpful. We don't know, and there probably will not be one drug for everything, but different drugs. It can sometimes be hard to distinguish the effects of the cancer itself versus the radiation or chemo.
What about taking medicines for sleep at night? How does that affect you?
Right. So I would not say that one should certainly minimize medications for sleep and try non-drug alternatives to the extent possible. Things like turning down having consistent bedtimes, turning down light towards the evening, exercising earlier in the day. However, in certain situations, such as a situation of jet lag or stress, using medications for a few days does not seem to be harmful.
Not an ongoing.
On an ongoing basis, it clearly clouds your attention, speed of response. Whether it has an impact on the Alzheimer process is less clear.
I'd be interested in hearing what your observations have been about trends in families, what you've seen in generations where Alzheimer's has been among several family members.
So, one of the earliest clues to the biology of Alzheimer's came from large families and what was called early onset Alzheimer's, and we found the genes amyloid precursor protein presenilin 1 and 2. Some of the presenilin 1 families have people who develop the disease in their 70s and 80s. So sometimes people who develop dementia later could belong to some of those genetic autosomal dominant families. In general, if somebody in the family has dementia, a person's risk is about 5 times greater than if nobody in the family had dementia. But that does not mean that they will get it. And a big marker is at what age the other family member got it. So that people, if they got it later and later, there's less and less of a risk to the others in the family. But if there are multiple people who have the disease in a given family, it's always good to know what the disease is. Certain types of dementia, like frontotemporal dementia, are actually even more strongly run in families than, say, Alzheimer's. And it's interesting that one of the genes, presenilin 1, was actually discovered in Volga Germans, in German families that had moved to Russia. So we know about 50 to 60% of Alzheimer's is inherited. We know genes, about 30 genes, but these explain less than half of the known heritability. So there are still genes to be discovered. The best thing to do if you're worried and there's a family history is talk to the doctor, get tested, and then be on follow-up.
Thank you. To begin with, I would like to thank Bill for recruiting you and bringing you to San Antonio. And as we have talked before, your goal is to achieve the visions, the goal, and the desires of Ann and Glenn Biggs, which we fully support. My question would be, is there a copy of your presentation in plain speak that the participants tonight could have, or could you refer us to something else? You've given us a lot of information, the technical terms, but the graphical information and the statistical information is very important, and if we can opine upon it, at our leisure, it's going to be more beneficial. And again, thank you for being here.
Thank you for those very kind words, sir. I'm so delighted to be in San Antonio. We will have this talk on our Biggs website. Some of the talks that the public lectures, dialogues on dementia, also we record and put them there. We have links to the papers that are cited, and some of the papers we are able to put there. Some, for copyright reasons, we can't do that, but you can always, if somebody's particularly interested, we can send a copy.
Yeah, I've got a question, a practical question. I'm a physician, ear, nose, and throat, not dealing with Alzheimer's. But it's becoming more and more difficult for all of us in the medical community to find a neurologist to whom we can send a patient. The average person in this room wouldn't know that, but there are very few neurologists around. The reimbursement, I assume, the reimbursements are so low, they can't support their office overhead, and so they either retire or join an institution. So I guess my question is, how do we get a patient into the system to be evaluated for Alzheimer's? Because right now, if somebody came to me and said, I need help with that, I wouldn't know where in the world to send them other than to you. Which is a good idea. But and this may be a bigger problem than we can talk about tonight, but that is a major problem, trying to find neurologists to address this.
that is a very big problem, and I must again thank President Henrich and Glenn and Ann Biggs. One of the things that made this position attractive for me was that generous donors in San Antonio put aside some money for us to help the most needy patients, to make sure that people are not, that we don't turn them away. So we are accepting Medicaid, we are accepting people without insurance. You know, obviously it's a finite amount of money, but we are certainly, we want to see everybody. There is a systemic issue that procedures are reimbursed better than time spent talking to people. And the way to manage this partly is to, whatever we don't need to have a physician do, we have a team approach. So we have a counselor, a social worker, a very good neuropsychologists who know the biology of the disease as well, who team with us. And so that way, but also we are looking to recruit neurologists and advocacy in Austin and DC to change this reimbursement pattern. Will definitely be helpful.
Just to comment about that, this is it's a very smart question. If Sudha spends an hour with a patient and takes the complicated history from the family, goes through all the drugs, goes through all the hospitalizations, goes through everything that's happened to the person, and it's really the cycle of their whole lives. The reimbursement for that's about $180. And with that $180, you've got to pay for all the people who made the appointment, the air conditioning, the lighting, the depreciation on the building, all the equipment in the center, and the individuals who put the people in the room, the people who cleaned the room, the people who, let me just say, I never thought as a nephrologist I would know anything about this, but I know a lot about it, and it's why there are no Alzheimer's centers in practice, because even under the most austere financial management, you can't do anything but lose money. So our strategy here was to start with the fact that we would obtain enough endowment money that we could defray the operational costs of the clinic and supplement it with the clinical earnings we would have in order to make the business plan work. And it was good for a couple of things. First of all, it was good that the generous people of San Antonio contributed to this project on just the promise that we would ultimately recruit someone like Sudha Seshadri to San Antonio. I don't know how lucky we are to have her. And I'm grateful, I mean incredibly grateful to this community which has been so generous to us in establishing this. So it's just getting started. I'd like to ask just one question in closing, and that is how do we reach you? How do we, and by the way, as a person who has drunk diet sodas and loses my cell phone regularly and has a stressful job, I am so worried right now that I'm not going to be able to find my car. I have Mary with me, which is helpful. So how do we reach you? What's the best way to find you?
So we have a website. This was on the first slide. There's also a phone number, 210-450-8437. And we've just, as of yesterday, hopefully operational by next week, we'll have a 24-hour hotline where you can call in. On the website, you can indicate if you want to be on a clinical trial. If you call into the number, if you want to be on a clinical trial, they'll get back next day. If you want to be in clinic, then they've given you a number to call for the appointment. We are backed up right now.
We need the number.
Right, 210-450-8437. I can give you my card as well.
You might point out that they need a referral.
Listen, the hedge on that, and by the way, the hedge on that for anything that anybody in the audience needs is to call me.
Yes.
Just call me, and I'm easy to get.
It's important that they get a referral from their family physician to be able to see somebody in your deal. Is that not correct?
At this point, we are accepting, if somebody I talk to and it seems they really have a problem, or one of our social worker screens, we are accepting. It's a little different from what we have traditionally been doing in neurology. Again, like I said, but ideally, yes, it would be good if you do consult first with the family physician, because that's a partnership for care, and that's what we would want to do. A center like this cannot look after everybody who has memory problems, and it's best done as a multiplier working with family physicians. However, in a given case, if somebody has no insurance or something and they want to reach out to us, we will.
Or if they don't have a family physician or something, then and a lot of people, surprisingly today, don't have that and need a referral. So the bottom line is just reach out to either Sudha through this website or through her numbers, or just call me, and I'll make certain that I hook you up expeditiously with her and with her people. Thank you all for coming tonight. Nice to have you.